Thank you so much for this opportunity to share experiences from East Central Uganda. And the presentation is about the contribution of lay healthcare providers in scaling up Option B+. And in this case, the lay healthcare providers are mentor mothers who are as a result of the mentor mother model that is being implemented by Mothers to Mothers. Mothers to Mothers is a peer education, and it's an organization that supports peer education and psychosocial support interventions to prevent mother-to-child transmission in 6 countries. And the 6 countries include Uganda, Kenya, Malawi, Lesotho, Swaziland, and South Africa. In Uganda, Mothers to Mothers is implementing the model as part of a consortium that is led by JSI and funded by USAID. The mentor mother model is currently being implemented in 45 health facilities in 9 districts under the Strengthening TB and HIV Responses in East Central Uganda in Short Star EC project. And the regional HIV prevalence is 5.8 compared to the national HIV prevalence of 7.3. Briefly about the mentor mother model, it recruits lay mothers living with HIV with recent PMTCT experience who have disclosed their HIV status and are willing to support their peers at local health facilities. Prior to employment and deployment at a health facility or health facilities, the mentor mothers undergo training in basic HIV knowledge with emphasis on maternal, child health, PMTCT, disclosure, and documentation. At the different health facilities, they provide health education with emphasis on PMTCT. They also pre-screen their clients for malnutrition, TB, cervical cancer, and gender-based violence. They provide psychosocial support to their peers through support groups, one-on-one sessions, one-on-couple sessions, and they also support intra-facility and facility community linkages to ensure that their peers get a comprehensive HIV package and other wraparound services. They also actively follow up mother-baby pairs and pregnant women who are HIV positive and have missed key appointments. They basically facilitate task shifting of non-clinical work from health workers, giving health workers enough time to attend to clinical work. So prior to the rollout of Option B+ in East Central Uganda, there are a number of barriers that were identified that were affecting linkages to pre-ART and ART. And some of these key barriers included poor linkage of eligible clients to pre-ART and ART. There was a huge gap between the ART clinics and the PMTCT clinics. Therefore, there was need to bridge that gap. And then among the psychosocial support group members and other PMTCT clients, there were misconceptions related to ART initiation. Some of them had observed or witnessed their neighbors in the community die just after ART initiation, just because they had started treatment late. And those who knew the benefits of ART or treatment, they had fear of side effects. And then there were also challenges to do with non-disclosure, especially among young women and women in new relationships, because they were not sure or whether their spouses would receive the message in a good way or chase them away from home. Therefore, to mitigate the barriers and strengthen linkages, mentor mothers were facilitated to proactively identify and link their peers to health workers for ART initiation in April 2013. There are a number of activities that were conducted to ensure a successful rollout, and some of the key activities included scaling up the mentor mother model and the peer-led PMTCT psychosocial support groups from 28 to 45 health facilities. Then the mentor mothers were trained in a customized package on Option B+, tailored to their understanding and their roles. And then during the sessions, they were supported to brainstorm on strategies that could accelerate ART initiation and ensure retention in care. And one of the strategies that was identified during the training sessions was to utilize the facility-based psychosocial support groups to ensure that the intervention was scaled up in a short period of time. So when they went back to their respective health facilities, they reviewed client records, the medical records, and identified their peers who needed to be enrolled on ART. So from that exercise, it was revealed that only 50% of 1,564 members in the psychosocial support groups were on lifelong ART, and therefore the other 50 that was on option A needed to be supported, especially given the fact that they were feeling healthy, and previously the mentor mothers had communicated that, you know, when you're healthy, you don't need to be initiated on ART. So at this point in time, the message was changing that regardless of your CD4, regardless of how you were feeling physically, you needed actually to be enrolled or initiated on ART. So there was there were a lot of things that needed to be done and messages that needed to be put forward to ensure that clients accept ART initiation. So mentor mothers worked in collaboration with other community linkage facilitators at community level where they existed, and where they didn't exist, mentor mothers went down to the community and mobilized their peers to come and attend the psychosocial support groups. So during the support groups, the mentor mothers provided education on option B+, and they also had time to interact with eligible women individually in one-on-one or one-on-couple sessions to encourage them to accept ART initiation. And thereafter, they linked their peers to health workers for ART initiation. They encouraged their peers in support groups to share testimonies, because not all the support group members accepted to be initiated on ART in the first month. There were those who were still hesitant. Therefore, they encouraged support group members to share testimonies, to share their experiences, so as to encourage their other peers to accept treatment. And then during the support group meetings, they also identified their peers who had missed their subsequent appointments, and they were able to actively follow them up to persuade them to come back to the facility for treatment. So over a period of 3 months, the proportion of pregnant and lactating women in psychosocial support groups that were linked and started on option B+ or ART increased from 50% to 98%. And recently, when we looked at our program data, the linkages are still sustained. When we looked at linkages of PMTCT clients to chronic care, the linkages were at 92%, and from chronic care to ART, they were at 93%. Besides mentor mothers linking their peers for ART initiation, they also linked them for other services. For example, they linked 77% of their clients who needed a baseline CD4 test to test. 77%, to some people, it might not be so good, but given that more than half of the facilities where mentor mothers are supporting their peers are in the rural areas, I think 77% was a great achievement. Then the mentor mothers linked 93% of mother-baby pairs who were due for a fast PCR, and they were able to get the test. And then they also supported 94% of mothers who needed to disclose their spouses, to disclose their status and get support from their spouses. In the subsequent quarter, mentor mothers continued to conduct the support groups and screening and finding out whether some of their peers had missed their appointments. And from that exercise, 104 of their peers had missed their appointments for ARV refills. Therefore, they conducted active client follow-up, and this includes follow-up in the community through home visits, through phone calls, through SMS, and sometimes through their counterparts in the community. And the follow-up is only done on clients who have consented to be followed up. So from the active client follow-up activities, mentor mothers were able to trace 96% of their peers, and they persuaded 86% of them to come back to the health facilities and get their treatment. Key factors that contributed to the success include the training of mentor mothers prior to the rollout of Option B+. As I said before, they underwent training. So this training prepared them, gave them key messages to pass on to their peers. They felt valued, they felt important, and therefore they moved back to their respective health facilities with energy, ready to support their peers. And then the use of a peer approach, a number of mentor mothers were being initiated at the same time with their peers. Therefore, they were sharing from experience, and they could easily be believed by their peers. Then the teamwork among mentor mothers, health workers, and other linkage facilitators. Each actor here knew their roles in the rollout of Option B+, so they looked at each other as a team, and therefore they respected each other and worked together. Then the availability of drugs supported by STAR EC and Ministry of Health. Usually, sometimes Ministry of Health deposits drugs at STAR EC, and STAR EC supports in distributing and redistributing. So during that period, there was availability of drugs and there were no stockouts. In conclusion, mentor mothers providing peer-led psychosocial support and linkages through support groups are important channels in the acceleration and adaptation of new PMTCT interventions in the resource-constrained settings. Special thanks go to mentor mothers and other linkage facilitators, health workers, Ministry of Health Uganda, USAID, STAR EC program, and its partners. Thank you.
Jill Gay, What Works Association. My question is for actually all the presenters, how you have addressed the issues of loss to follow-up in terms of gender issues. There are high rates of gender-based violence in both Zambia and Malawi, and high rates of gender inequality, and how you looked at those issues, and for mothers to mothers, how once the women disclosed to the men, what were the outcomes for those women?
So let's have just 2 or 3 questions to the speaker, and then we'll have her sit down and have the panel address that. So do you have a response to how mothers to mothers worked around domestic violence? Do you have any work around that?
Yes, domestic violence or gender-based violence is a new area that we are moving into, but currently mentor mothers have undergone basic training on how to tell signs to identify their peers who are faced with domestic violence. And usually domestic violence is common among mothers who have either newly tested HIV positive, those in discordant relationships. So during the support group meetings, they usually check on such women to find out how they are faring at home. And what they do is just to provide the education and also inform their peers where they can get help, and where they identify a case that is affected by domestic violence or gender-based violence, they refer to the health workers, and then the health workers take it from there. Thank you.
Thank you. We'll take one more question for the speaker. Is anyone up here? Number 4, and then we'll ask you to sit down. We can open it up.
I'm Jacqueline Balunji from Baila, Uganda. Thank you for your excellent presentation. I just wanted to know, were these psychosocial support groups facility-based or community-based? And also, what are some of the challenges the peer mothers faced in encouraging women to join the support groups? Thank you.
The support groups are facility-based, and mentor mothers they didn't experience any challenges in convincing their peers to join the support groups, because they shared experiences in different waiting areas, the benefits of ART initiation. So it became very easy for their peers to join. And also they did tell them that ART is, like, it's optional. You have to be ready. No one will be forcing you to take on treatment when you're ready. So they encouraged them, they shared experiences, and even those who were attending support groups, when they went back to